Thank you for being here.
All right. Thank you, Meg, for putting this all together. And thank you all for taking the leap of faith and joining us for this first session for the REPP series. This is an exciting new thing that we are doing, and we can only do it with your help. And we greatly appreciate you filling out those forms and getting this CME credit. So if you like what you're seeing, great. Let us know. If you think it sucks and was a waste of your time, let us know that too, and we will make it better. And feel free to share the resources with your colleagues. I worked at the community health centers here in Salt Lake City for over a dozen years, and I very much know what it's like to try to take an hour and learn something at your lunchtime, so I greatly appreciate you taking I think they got it. Now, and I bought a house. And I'm the first person in my family to do those three things. And then she, a moment later, said, and there's no way that I could have done that without having this IUD and without getting it, and I couldn't have got it without being in this study. So that's certainly a good reason for me to keep showing up to work, and hopefully what we'll discuss today will help you share information with your patients and provide them with more effective methods of contraception. That face I'm making is the sign of the slide not moving forward.
Is it moving forward on your laptop?
No. Let's try this.
Arrow keys are typically better.
There we go. Awesome. Okay. So we're going to talk today about reproductive anatomy and physiology and how that influences contraceptive mechanisms of action. Oh, we don't need that because you already saw what I look like. Okay. So the disclosures: the University of Utah's Family Planning Division receives a research support from a variety of industry sponsors, and we have been able to provide contraception without cost because of a lot of these associations, and I'm a speaker, or have been in the past, for Merck, Teva, and Medicine 360. The learning objectives for today are to apply reproductive physiology to better understand contraceptive mechanisms of action and to be able to explain contraceptive options by efficacy and mechanism of action to patients, to let your patients know how these methods work and how they can help them achieve their life goals and hopes and dreams. So I think a couple of things that are important to remember, and these will be the focus of additional talks down the road, but contraception is almost always safer, much safer than pregnancy. And we spend a bunch of time thinking about the risks of birth control methods, but nearly in every single instance they are much safer than no method, especially relative to pregnancy. And then Understanding mechanisms of action of different methods will help you better able to counsel your patients about what methods they think might be best for them. And one of the big, I think, overarching principles of all of these sessions will be our job as providers is to allow people and provide them with information so that they can make their best decision based on all the available options. This is not about finding or directing people toward the one thing that you think is best or I think is best. It's about independence and autonomy and patients making decisions for themselves. For this particular session, two big takeaways, things to remember and think about when you're thinking about the mechanism of action of these different methods is sperm can live for several days, like 3 to 6, post-intercourse. An egg is only viable for 24 hours after ovulation. We'll look at different ways that that influences different methods in physiology. Progestins, as a method of hormonal contraception, keep the egg and sperm away from each other by 3 main mechanisms, and that is preventing ovulation centrally through the hypothalamus-pituitary axis and at the ovary. Number 2, by altering the cervical mucus, and the best example of that, and we have a fabulous picture of this with the levonorgestrel IUD. It's something I like to call the Great Wall of Mucus. And then finally, by thinning the endometrium and interfering with tubal motility. If you think about it, a woman of reproductive age who, on average in this country, may have 2 pregnancies, spends about 3 years trying to get being pregnant and in the immediate postpartum period, which leaves 30 years avoiding pregnancy, which means that we need to do a good job to help people get the methods that work best for them over those 3 decades that they'll need them. So understanding some reproductive physiology comes in awfully handy for this kind of thing. During your training, at some point, almost certainly you saw something like this. And having seen that in the past, you may be cringing now. But let's just make this as simple as possible, because it can be very helpful as we discuss various methods of birth control. So during the follicular phase, there we go. Got an arrow here, you see that? So if we look down here, as you're looking at the left-hand side of the images on the screen, that represents the follicular phase, generally the first 2 weeks of the menstrual cycle. This purple line here just above that arrow is progestin levels. During the follicular phase, basically no progesterone around. And then later, during the luteal phase of the menstrual cycle, progesterone increases. It turns out that during pregnancy, the main hormone of pregnancy, the progestational hormone, conveniently called progesterone, exerts a negative feedback effect on the brain, on the hypothalamus, and it prevents pulsatile GnRH, gonadotropin-releasing hormone release, which triggers FSH and LH, which are critical for the menstrual cycle, FSH influencing estrogen release and LH progesterone. And at the level of the ovary, it blocks the effect of those hormones and interferes and prevents ovulation. Now, it turns out that if we provide exogenous progesterone, or progestin, we can essentially replicate that same thing that happens in pregnancy by tricking the hypothalamus to stop its pulsatile GnRH release and thus inhibit FSH and LH and thus prevent ovulation. So it ain't, of course, quite that simple. What is? but it's a good foundational building block for understanding a bunch of the contraceptive effects. And progestins also, as I mentioned earlier, have an effect on the mucus in the cervix and mess it up, and we'll talk a little bit more about that, and on the endometrium. And depending on the progestin and the way it gets delivered, that effect at the ovary to prevent ovulation, at the cervix to thicken mucus, and on the endometrium, which obviously has effects on menstrual bleeding, vary. And that's what we're going to talk a bunch about. However, first, let us talk about that sperm and egg interaction that we're trying to prevent. So, in this little depiction that Amna Dermish, a former family planning fellow of ours, developed quite some years ago when she was using it as a tool to explain emergency contraception, during sex, sperm are deposited close to the cervix and the vagina. A very small proportion of them are able to navigate through the cervix, through the uterine cavity, into the fallopian tube, the only place where they can fertilize an egg. And in a rare moment and aspect of physiology relative to males, sperm can actually hang. They can hang for up to 5 days in this setting and await ovulation. Now, as I said earlier, eggs post-ovulation are only viable for 24 hours, more or less. So it's only 1 day. So intercourse that happened days before ovulation can result in a pregnancy. And that's particularly important when you're thinking about emergency contraception, but other methods as well. And then should sperm and egg be available in the fallopian tube at the same time, fertilization can occur, sometimes smiley face, sometimes not. That first split, aligning the genetic information from a single sperm cell and a single egg cell to the next stage where there are actually 2 distinct cells post-fertilization, takes an entire day. And honestly, I often marvel that any of us are walking around because there is such an incredibly large amount of information that needs to be exchanged and perfectly aligned. That also explains why the inherent miscarriage rate is very high. So lots of times this process does not work out. But when it does, implantation usually occurs at about day 6 after fertilization. And implantation is the universal definition of pregnancy. So this slide just quickly details sperm attrition. You can see from that purple curve that's essentially tracking the number of sperm. There are a lot, hundreds of millions of sperm in each ejaculation. It's a couple cc's on average that quickly pass off. And this is why sex is a messy business, because many, sperm only occupy 5% of the ejaculate fluid, but a lot of it, the majority of it, doesn't stay in the vagina and doesn't stay by the cervix. And, hundreds basically make it through navigating the cervical mucus and the cervical canal to the fallopian tube. This image depicts essentially what happens post-ovulation with fertilization on day 0 in the fallopian tube. A day later, the fertilized egg undergoes its first cleavage. So on day 2, there's 2 cells. And it takes several days to pass through the fallopian tube and implant. The blastocyst slowly developing. Now, we had talked a little bit about estrogen and progesterone in that previous schematic of the menstrual cycle. And estrogen can be thought of as constructing the building blocks, or they used to say when I was in medical school, estrogen was the fertilizer and progesterone was the lawnmower. And I think this is a slightly different approach where estrogen essentially assembles the building blocks and progesterone provides that cement. And in the later part, to keep the wall intact, and in the later part of the menstrual cycle, when the progesterone disappears, you have essentially a breakdown of that wall and menstruation and bleeding. So overall, progestins and estrogens, but mostly progestins, inhibit ovarian function at the level of the pituitary. And almost all of the contraceptive effect from birth control methods and hormonal birth control methods for systemic methods comes from progestin inhibiting ovulation. Progestins also thicken cervical mucus. They generally atrophy and thin the endometrium. It can be helpful for cycle control. Estrogens have a minor contribution, but a little bit of addition to inhibiting ovarian and pituitary function and thin cervical mucus and help proliferate the endometrium, and also have a role in cycle control. So there's a variety of progestins that are available, and this will reflect back to this. You do not need to know the details of this. Any self-respecting medical student, of course, who saw a slide like this would want to know exactly what they needed to know for the test. And any self-respecting community health provider would want to know, what do I need to know about this that helps me take care of my patients? And it's a lot more fun to be talking to you in that regard. So I think what's helpful to know here is that progesterone and its derivatives, the one that we use most frequently here is medroxyprogesterone acetate, and you know that is the main, that's essentially the ingredient in Depo-Provera, the injection. And then the vast majority of hormonal contraceptive methods come from this 19-nortestosterone group. And there are estranes and gonanes. Most of the modern progestins that are used in combined pills and in other methods are in this group, and the reason is they have fewer adverse effects. A common, for example, a common birth control pill that's available in a monophasic form, that's available as a generic with a low dose of estrogen is Sprintec. It used to be orthocycline, and that's norgestimate. Desogestrel is a derivative of etonogestrel, which is in the implant and in the ring. Drospirenone is the main hormone that is not a 19-nortestosterone, and that is in Yaz or Yasmin and those. And these are the only group of pills that are associated because of their 17-alpha spironolactone derivative, which is a diuretic, is the only thing that's associated with decrease in blood pressure and weight over time through that diuretic effect. So this is a chart. It comes from something called the bedsider.org, which is a website I strongly encourage you to check out if you haven't already. And this is a common method that people use to share contraceptive methods, and it's essentially efficacy, by efficacy. So the most effective stuff, the implant, the IUDs, sterilization is at the top. This is stuff that works really, really well. And on the looker's right of the screen, you can see a nod toward that efficacy. And it basically shows that if 100 couples or 100 women use this over the course of a year, 0 or 1 people would have a pregnancy. In the next pill, patch, the ring, the DEPO shot, these things work, and they work well. But over the course of the year, we would expect something more like 6 to 9 women out of 100 having a pregnancy using those methods. And it turns out that being a human being really affect that. Those top methods are set it and forget it methods. Once they're in place, you have to do something to make them not work. These other things require some maintenance along the way. And then finally, there are things that are effective, but not super effective. And those are all non-hormonal methods, but withdrawal, the diaphragm, barrier methods, condoms, fertility awareness, and the expected pregnancy rates there in the 10 to 20s. So I think it's helpful to start with fertility awareness when you're taught, especially when the framing of the conversation is physiology. And the fertility awareness methods involve a bunch of different ways to get it done. Daily tracking of the menstrual cycle is key to all of them. Some use body temperature, cervical mucus assessment, assessment of urinary hormones. There's apps and online methods and things to help people do this. The users of these methods either need to avoid sex during their potentially fertile period and or use a backup method on those fertile days. These methods can have an efficacy of 99%, where 1% of couples will have a pregnancy. But again, it requires fastidious attention to what people are doing. They can be available anywhere, but people need to be educated about the method they're using. And it has some major advantages, like no hormones. Critical to understanding fertility awareness methods is the idea that eggs survive 1 day post-ovulation, and ovulation can be predicted. Sperm survive 3 to 6 days post-ejaculation, and sperm must undergo capacitation in the fallopian tube prior to fertilization. And that means essentially, in order for a sperm to penetrate an egg, it needs to undergo a molecular change in order for that to happen. That has to happen in the fallopian tube. All of this means that people need to avoid sex, and commonly that's for about 12 days in the middle of the cycle, or use a barrier method during that time. And it's worth considering there are some very serious advantages of fertility awareness methods. Once you get what's going to help you assess your monthly fertility, they can be free. They don't require you going into a healthcare provider. It gives an opportunity for people to get to know their bodies better. If you have a cooperative partner, it's a great way to connect with your partner. And again, no hormones. As a public health intervention, these are not necessarily tried and true methods, though there's some information coming out on those as time goes on. There is a possible investment to make in some of the methods. In general, typical use has low efficacy. It does require daily attention, and it requires a partner that's cooperative, and it doesn't provide any protection against sexually transmitted infections. This is a graphic of essentially of how the cervical mucus changes over time. If you think about many of the wonders of the human body, and especially as it relates to reproduction, mucus is almost all water. It's got some glycoproteins that radically change its formulation from these channels, like the estrogen type of mucus on fertile days, to progesterone influenced mucus, like great wall of mucus there on the right, at later points. So now we're going to just flip through a couple of different methods and see how they affect what we learned about physiology. Male condoms and dual protection are a good place to start after looking at fertility awareness methods. We're working our way up that bedsider chart from less effective methods to more. And condoms are widely available. They have an ideal use failure rate of 2% and a typical use failure rate of 18%. They do require some partner cooperation, and they are widely available, but there's something that needs to be used with each act of intercourse. There are also female internal condoms. And the joke about these when they first came out was this is like having sex with a Hefty bag in your vagina. However, the plastic that is now used to make female condoms is much thinner and more pliable and adherent to the vaginal sidewall and much more comfortable for people. And these are also widely available, though not as much so as male condoms, again, are required at each active intercourse. And both of these things provide sexually transmitted infection protection, though not perfect, sure, and they both avoid hormones. I think one of the big advantages of both of these, of male and female condoms, is as an additive to other methods. Everything works better when, I guess, with efficacy as a measure. Everything's efficacy is better with condoms in use. And they can add, and that's the idea of dual protection in methods. So a birth control pill has a typical use failure rate of 8 or 9%, actually goes down to much lower, much closer to 1% when people are using both birth control pills and condoms. So certainly something that's worthwhile recommending to your patients who are using other methods as an additive and augmenter of efficacy for other methods. So diaphragm, this is something that's really evolved quite a bit, that's not used all that much, but you know, diaphragms, similar to condoms, essentially create a barrier covering the cervix, and they're used with spermicide. And they block sperm from entering the cervical canal and from passing up through the uterus into the fallopian tubes. They need to be left in place 6 hours after sex, but can be placed up to 18 hours before. The standard diaphragm that's been used for decades is required a fitting in various sizes. However, now, thanks to modern technology, a group of women who are interested in developing a better diaphragm and the internet, you can order this thing without a visit to a medical provider for about a little under $100 on the web. And this is called Kaya, and it's one size fits all. Again, also used with spermicide, and have a 6% ideal use. So for barrier methods overall, these are essentially cheap. They don't require a healthcare visit except for the old kind of diaphragm. Cervical cap is also included in this. They're good methods for infrequent intercourse and are frequently used for that. They do provide STI protection. Dual use also has the benefit of giving males an opportunity to contribute. And they all don't require use of hormones that lots of people don't like the side effects of. You know, downsides are lower efficacy and attention required with each active intercourse. And STI protection is not perfect, but also all require some partner compliance. So again, back to that physiology graphic, we're going to talk about some hormonal methods and their mechanisms of action. Progestins interfere with ovulation, that purple line. They also thin the endometrium and have some effect on menstrual bleeding, and they mess with cervical mucus through progesterone. So the most common method of contraception in the United States is oral contraceptive pills. And the most common method there are combined pills that include estradiol, ethinyl estradiol, and some progestin. So there are nearly 100 different types of combined birth control pills available in the U.S., and you do not need to know that many. And knowing one or two will be very helpful to your patients. And again, as I said earlier, a monophasic method that's got a modern progestin like norgestimate and a low dose of ethinyl estradiol with the same amount of hormone in each pill that can be used either cyclically, so 21 days on, 7 days off, or continuously, 28 days, and then essentially beginning a new pack. So take the 21 active pills and then begin a new pack immediately for continuous use. So these things can be as effective with pregnancy rates of less than 1%, but typical use is closer to 8%. And they require daily use. Commonly, people who are on birth control pills miss 3 pills per cycle. And that is part of the reason why it doesn't work as well as it might. NuvaRing is probably more effective because it can be left in place. And again, it can be left in place for 28 days and a ring switched out and used continuously, or cyclically, left in place for 21 days and removed for 7 or shorter. All of these methods that contain estrogen have a risk for venous thromboembolism, DVT, and PE, and all of that risk is lower than pregnancy, certainly, and essentially doubles a low risk for non-pregnant people who are not on a hormonal method. And that means essentially the difference between 1 in 10 or 20,000 to 2 in 10 or 20,000. And it turns out that 2 times a very rare thing is still a very rare thing. And again, much safer than pregnancy. The patch requires weekly switching. It can again be used continuously, where you put a patch on every single week, or cyclically put it on 1 week, 2 weeks, 3 weeks, and go a week without. So overall, these combined hormonal methods have upsides. They generally are cheap, and once you have a prescription for a year that you have provided, thank you very much, people don't need to come back and see you for a year. They frequently, if people have some kind of healthcare coverage, and at most pharmacies they can get about 3 months' worth at a time. Generally, providing people with a year's worth means they're more likely to continue. They're the most commonly used methods, but people do miss and don't get packs filled. And with birth control pills, somewhere between 1/4 and 1/2 of people who begin pills each year are actually still using them at the end of the year. That is low, and why we're going to talk about some other methods very shortly. Progestin-only pills don't have that estrogen component, don't have an increased risk of venous thromboembolism and clot, and do require being taken at the same day and are more likely to have irregular bleeding. Depo-Provera is a huge amount of progestin, and this stuff works great for some people. You have to come in once every 3 months. It does a very good job of suppressing ovulation and knocking out function of the ovary. It thickens cervical mucus and thins the endometrium. And it really has a very strong effect on bleeding and ovarian function. It's so much progestin, so much more than any other method here in this graph compared to the implant, that it's likely the cause of a bunch of different side effects. So about half of people who get, who get Depo-Provera for more than 2 shots will not have any bleeding after 6 months. There's a small group of people who gain a bunch of weight with Depo-Provera, and they will let you know about it, and many of them don't like it, understandably. It's the only hormonal method, the only reversible method with a slow return to ovulation and fertility. All the other methods, birth control pills, IUDs, implants, you start that thing. When you stop it, your fertility returns to normal right away. And then because it has such a strong effect on blocking ovarian function, there's bone loss due to Depo-Provera use. And that is reversible when you stop it. So we're going to talk a little bit about long-acting reversible methods, and there'll be a bunch more discussion about these in future talks. These are expensive without insurance. They are generally useful for 2 years beyond the FDA indication. And for the copper IUD or Paragard, that means FDA approved to 10 years, good data to show that it's useful out to 12. The levonorgestrel 52 milligram IUD, Mirena or Liletta, FDA approved for 5 years, good for 7 for sure. Etonogestrel implant, Nexplanon, FDA approved for 3, good for 5. The lower dose levonorgestrel IUDs are good for shorter periods of time, and we don't have those data for extended use. So the implant is an awesome thing. The efficacy level for this method is superb, outstanding, probably the best thing that we have. These things are super easy to put in, and through this program and some other trainings that you'll hear about over time, anyone can learn how to put these things in. It's like putting in an IV, but you don't need to hit a vein. As I had said, they're good for 5 years, though FDA approved for 3. And they work phenomenally well by inhibiting ovulation, but not completely shutting down the ovary like Depo-Provera does. They alter the cervical mucus, they thin the endometrium and create a bunch of irregular bleeding. They don't have estrogen, so don't increase people's clot risk. And they do need to be required, they are required to be placed and essentially removed by a healthcare provider. People do get bruising almost all the time at the insertion site, and the device actually can be noticed. I generally tell people who are going to get the implant that about 1/3 of people will have no bleeding or less bleeding, about 1/3 of people will have about the same, and 1/3 will have more, and it will be unpredictable. In the end, though, 8 out of 10 people who get it are still using it at the end of the year. The copper IUD is an amazing thing. It's the only thing that we have where a woman can walk into an office and 5 minutes later walk out with something that has no hormones. It works as well as getting your tubes tied. It's totally reversible and can last for as long as they want, up to 12 years. So high efficacy and no hormones are clear upsides to the copper IUD. It's the most effective method of emergency contraception. People will have a normal cycle if that is desirable, and this is a great method for people who want that. It's about a 5% or less expulsion rate. There's obviously no STI protection, heavier bleeding, especially in the first 3 to 6 months, and rarely complications can occur during removal. The hormonal IUD there's actually several varieties now. The most commonly used are the 52 milligram versions, Mirena. And if you haven't heard of Liletta, we certainly hope you will. It's made by and distributed by a company called Medicines 360 and Allergan. And if you work at a clinic that has 340B pricing, your clinic can buy a Liletta IUD, which is made out of the same components of Mirena, works just as well, has the same positive effect on decreasing bleeding, and is available for $50. If that is news, hopefully that is exciting news. So the mechanisms of action of hormonal IUDs are they impair cervical mucus. This is the quintessential Great Wall of Mucus, which I'll show you a slide of in just a sec, and it can also impair tubal mobility. And they have outstanding efficacy, as good as sterilization, and are good for particularly Mirena and Liletta up to 7 years. So this is what I was talking about with the Great Wall of Mucus. This dense, really nearly impenetrable to sperm collection of mucus is the main mechanism of action. And it turns out that levonorgestrel also has a very high level inside the endometrium and creates a very positive bleeding profile. Specifically, it cuts down bleeding dramatically in a very predictable way. That's very different than the implant, but the hormonal IUD is generally 3 months of weird bleeding, could be more, could be less, could be spotting every day, something unusual followed by very little or nothing. And I think that's a reliable thing to share with patients. So just to review back to these mechanisms of action, in the top right there, methods used to block ovulation include progestin in the combined pill, the vaginal ring, transdermal patch, and Depo-Provera. Methods used to inhibit endometrial proliferation include all of those things, plus hormonal IUD, and then methods used to thicken cervical mucus include all of those, and again, the hormonal IUD. I wanted to thank Zoe Diener and Katie Panushka, who helped with a bunch of these physiology slides. And then as we approach the end here, levonorgestrel IUD, the upsides I think are widely publicized, but high efficacy, very reliable decrease or elimination of bleeding, a long duration of action from a single visit, and very low systemic hormonal levels. So the progestin only, no estrogen in this, and the levels are less than 1/3 of what it is with the lowest pill. So downsides, the thing can't be used if it's not inserted, and insertion is uncomfortable for most people. There's expense. There's no STI protection and very little bleeding following a period of irregular bleeding. And again, rare complications. Sterilization is obviously highly effective and not reversible. And I don't know if people are offering this in their clinics, but certainly vasectomy is something that can be provided as the better, cheaper, safer method of sterilization if that's appropriate for couples. And then just very briefly, emergency contraception. The copper IUD is clearly the most effective method. Almost nobody who has had unprotected sex in the last 5 days who gets a copper IUD put in has a pregnancy. Less than 1 in 1,000. Ella is worth your while prescribing as ulipristal acetate because it is more effective than what's available without a prescription, which is Plan B, which is progestin only, and and the reason for that is Ella, or ulipristal acetate, UPA, in the blue here, works better for women regardless of their BMI, and for Plan B, oral progestin or oral levonorgestrel at higher weights and higher BMIs has almost no effect. I'm going to skip over that, and just a quick reminder and plug for the copper IUD. If you have patients who've had recent unprotected intercourse, it works incredibly well, and it works incredibly well regardless of BMI, whether you've had more intercourse later in that same cycle and whether your intercourse occurred initially in the fertile window. So family planning is critical for personal and public health. A little reminder of that. Sure access to all methods for your patients, and if you have questions, I would be happy to have a chat. Okay, do we, okay. Yeah, if we have a little bit of extra time, it's probably worth talking a little bit about emergency contraception as it relates to physiology and why there's a variation in efficacy. I might flip back. But if people do have questions and want to type them in, please do. So the copper in a Paragard IUD is toxic to sperm, and certainly if it's inserted after somebody has had intercourse, especially if it's days later, it very well may interfere with tubal motility and the sperm-egg interaction and implantation. But it is the best thing that you can offer anyone who is concerned that they've had unprotected intercourse and doesn't want to be pregnant, for sure. Ella, ulipristal acetate, works very well up to the point of ovulation, and Plan B a little bit earlier than that, and is less effective. Again, remember, with emergency contraception or birth control that's used after intercourse, these methods are, thinking back to the physiology slide, sperm can be in the fallopian tube, and that what you're trying to do is, if ovulation hasn't occurred with these oral methods, is to prevent ovulation, and if it has, or regardless of where it is in the cycle, the copper IUD works extremely well. And I think I try to also talk a little bit about the differences between Depo-Provera and the implant. They're both progestin-only methods, and but the side effects are really quite different. Because Depo-Provera is over 50 years old, it's been used for a long time, and it was originally developed as a treatment for endometriosis, and it's very effective in completely shutting down ovarian function, or nearly completely doing that. It's a very, very high dose, and unfortunately, there are progestin injectable methods that are currently under development that might be a substantial improvement, but unfortunately these things take a very long time. And because it's such a high dose, it's the thing that people are most likely to have adverse effects and experiences with. But for the people it works for, Depo-Provera, it works very well. And it's also very reliable, again, because it's such a high level of progestin, and the progestin is very effective at blocking endometrial function. It's very effective at decreasing bleeding, whereas the etonogestrel implant is effective, incredibly, even more effective at blocking ovulation, but it does it without completely stopping ovarian function. And its effect on the endometrium is different because, first of all, the progestin is different, and then the dose is much lower that's circulating and provides less reliable effect on the endometrium. I think we have a question.
Yes. Somebody had a question around the newly FDA-approved one-year pathway and then the natural cycles app. So there were two questions around that.
Okay, awesome.
Yeah.
So the two questions were the new FDA-approved ring, which is ethinyl estradiol and I'm going to come back to you with the progestin. And essentially what's different about this ring relative to NuvaRing is the actual ring that you get. NuvaRing is you go to the pharmacy or it gets dispensed, and it's good essentially for 1 month. This ring, the new ring, is good for an entire year, and you can essentially put it in and take it out monthly and use it over the course of a year. So that's a significant improvement, I think. And on the downside is it's not available quite yet, though it is FDA approved, which is an enormous step in the right direction. It's not going to be available until there's some more marketing and production of the process. But this thing's been in development for over a decade, and there's actually a new one that's already being worked on. So more to come on that, and we'll see, but it's going to be a little while until you see somebody using that. And then, sorry, the other was the
natural cycles method that was FDA approved, the fertility awareness.
Gotcha. Me answering that with you here, Rebecca, seems a little gratuitous. Do you want to take that?
Yeah, I can take that. So the FDA, at the same time that it approved Annovera, the one-year ring, also approved the Natural Cycles app. Natural Cycles is a method of fertility awareness methods that Dave talked about earlier, and Natural Cycles has an essentially proprietary algorithm that women can utilize to identify their fertile window. So you will take your basal body temperature in the morning, if you're going to use this method, and input it into the Natural Cycles app, which will then calculate, using their proprietary algorithm, whether or not you are in your fertile window or not. And the background on natural cycles is they've done 2 different studies around efficacy and have shown that perfect and typical use are comparable to that of oral contraceptives. So I believe perfect use of the Natural Cycles app was 1.8 pregnancies per 100 women. And then the typical use, in the first study they did, they found a typical use of 6.5, but in a subsequent study that they did, there was a typical use rate of 9.1 pregnancies per 100 women over the course of a year. So essentially, in order to use it, you need to download their app, which costs about $13 a month, and they also try to sell the basal thermometer. But for women who are interested in utilizing this, it might be an option for them.
All right. Yeah, if people want to unmute themselves, please feel free to ask a question. Okay. And Meg will be sending you the post-test and evaluation form, and thanks for taking some time. And if you have other questions, also I think you have access to the slides, and at the end of them is my email address, which I'm happy to answer.
I wrote down everyone's name from the sidebar, but if you are under a different name or just under a phone number, if you would shoot me an email and let me know that you were here, that would be helpful. I'm just meg.waters@utah.edu. And I'll put that in the chat box.
Okay.
We'll leave it.
Okay. And then the next rep session is next Wednesday?
Next Wednesday.
Same time?
Same time, same place.
Same bad channel.
You'll have some emails.
All right.
All right, thank you.
Thanks, everybody.